What an insightful overview. Thank you, Professor Kotlanda and Dr. Uluwatage for chairing that session. Next, we move on to the first symposium of the day, focusing on the rational and effective use of antibiotics. This session, which is rightly termed as Right Drug, Right Way, Mastering Antibiotic Therapy, will be chaired by Dr. Upul Dissanayake, consultant physician and past president of the Ceylon College of Physicians, along with Dr. Dilshan Priyankara, consultant intensivist of the National Hospital of Sri Lanka, president of the Ceylon College of Critical Care Specialists. I cordially invite Dr. Dissanayake and Dr. Priyankara to chair the session.
Good morning. Our next speaker is Dr. O.C. Abraham, who's a professor and head at the Christian Medical College. He'll be speaking on the principles of rational antibiotic use. Over to you, Dr. Abraham.
A very good morning to everyone attending the ID Forum meeting of the Ceylon College of Physicians. Before I begin my presentation, let me express my thanks to organizers of this meeting, specifically the Infectious Disease Forum of the Ceylon College of Physicians. It's indeed an honor and a privilege for me to be here today, although I'm joining you virtually. My presentation is titled Principles of Rational Antibiotic Use. Antibiotics are wonder drugs, miracle drugs, in fact. This is a poster from Life magazine in 1944, which says that thanks to penicillin, he will come home. Virtually untreatable infections with 100% mortality became eminently treatable, and the effect was seen most dramatically during World War II casualties. So penicillin was truly a wonder drug. Antibiotics are special in many ways. Number one, what we have come to realize is that much like fossil fuels, antibiotics are finite and non-renewable resources. Why is that? This is for two important reasons. The discovery void and dry pipeline. From 1940 to 1990 was the golden age of antibiotic discovery. After that, hardly any new molecule with a novel mechanism has been introduced for practice. So the antibiotic pipeline is truly dry. Second is the increasing rates of antimicrobial resistance being seen across the world today. Once eminently treatable infections have become virtually untreatable because of multi-drug and pan-drug resistance. Antibiotics are special in another way that use in one patient will compromise efficacy in another because selection of resistant mutants among the commensal flora of the patient whom are using it can be transmitted to another person and thereby adversely impact the treatment outcomes in that person. We love antibiotics. We use plenty of it. To just quote some statistics, this is during COVID-19 antibiotic utilization in patients hospitalized with COVID-19. This is data from World Health Organization. As you can see here, only about 8% of hospitalized patients with COVID-19 had bacterial co-infections which truly required antibiotic therapy, while in actual practice, about 75% of them were being treated with antibiotics just in case. So why is this not a good thing? This is because we now know that antibiotic use, whether it is appropriate use, inappropriate use, overuse, or misuse, is one of the key drivers of antimicrobial resistance. Mutations occur spontaneously. Mutations can occur because of horizontal transfer of genetic material between bacteria. So it's a natural phenomenon. However, use of antibiotics will select out these resistant mutants and give them a survival advantage. Antibiotics are associated with numerous adverse drug reactions. To name a few, hypersensitivity reactions like anaphylactic shock, DRESS syndrome, severe cutaneous adverse drug reactions, acute kidney injury, drug-induced liver injury, encephalopathy, the list goes on, and many of them which I mentioned are potentially life-threatening. We also know that use of antibiotics will damage the good microbe inside us, the commensal flora. So one adverse effect of this damage to the commensal flora is the loss of colonization resistance and overgrowth of bad bugs like Candida species, Clostridium difficile, and vancomycin resistant species of Enterococci. And last but not least, cost overruns. I will talk during my presentation about the rational use of antibiotics, what I call the 3S approach. The 3S stand for: one is starting the antibiotics, two is streamlining the antibiotics, and three is stopping antibiotics. So the 3S approach. What I'm planning to do is that illustrate this principle by discussing two cases which I have seen recently. The first patient is patient S. She's a 69-year-old diabetic patient who has not been very regular with her anti-diabetic therapy. She is badly controlled diabetes. She presents to the emergency department with history of dysuria, painful urination, increased frequency of urination, and blood-stained urine for 3 days, followed by fever with shaking chills and rigors and drenching sweats for a day. On examination, her temperature was 103 degrees Fahrenheit, pulse rate of 124 per minute, rate of 32 per minute. SpO2 on room air was 84%, and the blood pressure was 86 millimeters mercury systolic. She has bilateral costovertebral angle tenderness. The second patient is an 84-year-old male, again a type 2 diabetic who has an indwelling history of malaise, change in color, and bad odor of the urine for about 2 days. On examination, his temperature was 99 degrees Fahrenheit, pulse rate was 66 per minute, respiratory rate was 20 per minute, and saturation on room air was 94%, and the blood pressure was 120/84 millimeters of mercury. Systemic examination was otherwise unremarkable, and the Foley catheter was draining slightly dark urine. The question to you is, which among these two patients, patient S and patient V, who needs empiric antibiotic treatment? Empiric meaning starting an antibiotic before you get the reports of culture and susceptibility from the laboratory. Well, before you decide who needs antibiotics, you have to make a diagnosis. Remember that inaccurate diagnosis is the most important reason, underlying cause for irrational treatment. And how do you make a diagnosis? You always have to consider multiple data points together. Please do not start an antibiotic for fever, no antibiotic for leukocytosis, no antibiotics for elevated procalcitonin levels or C-reactive protein, no antibiotics for pyuria, no antibiotics for a positive urine culture. You have to make an accurate clinical diagnosis. Diagnosing a UTI, we know that symptoms, especially combination of 2 or more symptoms like dysuria, frequency, suprapubic pain, have a very high positive predictive value, more than 95%. Pyuria, presence of WBCs in the urine, more than 10 cells per high-power field, or a positive dipstick test for leukocyte esterase is not UTI. Pyuria means inflammation of the urinary tract. It can be due to several conditions, including genitourinary tuberculosis, analgesic nephropathy, lupus nephritis, cyclophosphamide therapy, etc., etc., etc. But the value of urinalysis is the high negative predictive value. Somebody who is not neutropenic, pyuria is absent, will virtually rule out a significant urinary tract infection. Also remember bacteriuria. Presence of culturable bacteria in the urine is not urinary tract infections. We know that substantial number of patients, especially elderly, diabetics, those with indwelling Foley catheter, have bacteriuria, and this is they don't lead to adverse events like pyelonephritis and bacteremia and septic shock. So asymptomatic bacteriuria is much more common than symptomatic urinary tract infections. But then culture and susceptibility does have a value in identifying the causative organism and determining the antimicrobial susceptibility, which will guide definitive treatment. Also remember, in elderly patients, cloudy and smelly urine or fall in change in mental status accompanied by any other evidence of infection like fever, hypothermia, hypotension, metabolic acidosis is not UTI. So diagnosis of UTI is based on appropriate symptoms and confirmed by a urine culture, which will also guide you by the susceptibility testing. So when you start an antibiotic, the first question you ask yourself before you write the prescription is, does this patient have a bacterial infection that requires immediate antibiotic therapy? Remember that several bacterial infections, for example, acute bacterial rhinosinusitis or shigellosis causing bacillary dysentery in an otherwise healthy young individual, do not need antibiotic therapy. Antibiotics do not change the outcome. Empiric broad-spectrum antibiotics like carbapenems are required only in seriously ill patients, that is infection, pyelonephritis, pneumonia, meningitis, fasciitis, liver abscess, accompanied by organ dysfunction, kidney injury, respiratory failure, hypotension, DIC, etc. So this is sepsis. If you have septic shock, it's an urgency. You have to start antibiotics after drawing cultures as early as possible, preferably within an hour of recognition of shock. So please remember, empiric broad-spectrum antibiotics should be started only when a patient who has evidence of sepsis, that is infection plus organ dysfunction. Also, when you choose an antibiotic, make sure that the antibiotics are appropriate for the site of infection, appropriate for the likely causal organism, appropriate for the anticipated drug susceptibility report. So your hospital should have an antibiogram. You know that in pyelonephritis, the most likely organism is E. coli. And you know that in India, about 70 or 80% of the E. coli are resistant to third generation cephalosporin because of ESBL production. The antibiotic should penetrate the involved tissue, and you should always use the correct dose, route, and duration of therapy. So going back to the question, which patient needs empiric antibiotic therapy? The clear answer is patient S. Why? This patient has acute pyelonephritis, has symptoms of dysuria, frequency, costovertebral angle tenderness. Patient is seriously ill, is tachycardic, tachypneic, desaturating, is hypotensive, so needs immediate antibiotic therapy. Which antibiotic therapy will you start empirically after getting blood and urine cultures? If you're in India, this will be meropenem. Why? Because as I mentioned, E. coli is the most frequent pathogen which is likely to be present. And we know that very high rates of third generation cephalosporin resistance is prevalent in India. You also have to remember that when you have decided to start an antibiotic, dose optimization is extremely important, especially in critically ill patients like patient S. Why is that? These patients who are septic have marked homeostatic disturbances. For example, increased volume of distribution. There is capillary leak, you're pumping in liters and liters of fluids. There is altered end organ function, augmented renal clearance early in sepsis, patients with acute kidney injury, there is reduced renal function. All this will distort the pharmacokinetics. Remember, pharmacokinetics are studied in normal, healthy volunteers or patients with milder forms of illness. So in the severely ill patients, the pharmacokinetics are distorted. And how do you optimize dosing so that there is adequate levels of the antibiotics available at the site of infection, ensuring maximal bacterial killing? There are three things mentioned. Alternative dosing schedules like loading dose. You know that colistin is always given as a loading dose followed by maintenance dose. You use more than the recommended doses, and prolonged infusions. I will talk about this in a little bit detail. Therapeutic drug monitoring is currently being recommended increasingly, especially in ICU patients. But there are many problems in countries like ours. lack of wide availability, cost considerations, long turnaround time. And TDM is done usually in a steady state. And what you're interested is the initial antibiotic concentration, probability of target attainment during the so-called golden hour. And the next one is what is called pharmacokinetic model-informed precision dosing, MIPD, model-informed precision dosing. So you feed all the data, renal function, blood pressure, body weight, albumin values, creatinine, everything into a model, and model will churn out the dosing schedule for you. Again, therapeutic drug monitoring and model-informed precision dosing are in the realms of expert opinion and case series and observational studies. There are no randomized control studies which have shown these are beneficial. However, for prolonged infusion, especially for beta-lactams, in patients who are in the ICU with a diagnosis of sepsis or septic shock. This is a recently published meta-analysis of all the randomized control trials of prolonged infusion of beta-lactams compared with intermittent bolus dosing, and the outcome was 90-day all-cause mortality. There are about 18 trials, the biggest and most recent being the BLING, BLING 3 study, which showed that there is a definite improvement in mortality, relative risk of 0.86. The 95% credible intervals are given here. So there is a 99.1% posterior probability that prolonged infusion is associated with a lower 90-day mortality. So in a sick patient in the ICU with a diagnosis of sepsis or septic shock, prolonged infusion of beta-lactam antibiotic saves lives. And the number needed to treat is 26. Very impressive. That's the forest plot and the summary relative risk ratios. So the next S stands for streamlining antibiotics. Review of once you write an order for an antibiotics, the order should be reviewed daily. So it's a dynamic process and never static. Why do you want to review the antibiotic orders daily? And what are you reviewing? Number one, you are assessing the patient's clinical status. Is the patient becoming afebrile? Are the vital signs becoming normal? And are the culture and susceptibility reports back? Why do you want to do this? This is so that you de-escalate the antibiotics based on antibiotic susceptibility test reports and the clinical status of the patient. Once you have an organism identified and antibiotic susceptibility reports are known and patient is getting better, persistently afebrile, vital signs being normal, you can change from a broad to a narrow spectrum antibiotic or convert a combination therapy to monotherapy so that you get rid of the redundant or unnecessary antibiotics, narrowing of the spectrum and stopping unnecessary antibiotics. Discontinuation is probably the ultimate de-escalation. However, the expert guidance does not include this as a step in de-escalation. Why do you want to do this? To reduce collateral damage and antimicrobial resistance. Till now, one of the major criticism about de-escalation was the absence of well-designed randomized controlled trials to support this concept. Observational studies have shown that de-escalation is as safe as continuing broad-spectrum antibiotic therapy, but then the damage on the collateral damage and mortality advantage has not been proven yet. But now we have two well-designed randomized controlled trials, the so-called opt-out trial published in a recent CID and the simplified trial published in a recent issue of the Lancet. Opt-out trial is from the US of A and the simplified trial is from Spain. In the opt-out trial, what they did was patients outside the ICU who had negative cultures but were on broad-spectrum antibiotics were randomized to usual care versus discontinuation of the antibiotics. These patients, they were on broad-spectrum antibiotics, they had negative blood cultures, and then the investigators, after assessing eligibility, went through a 23-item safety checklist to make sure that they were not missing seriously ill patients who needed antibiotics, and then they were randomized to either continuing the usual care or discontinuation of the broad-spectrum antibiotics. They found that patients in the intervention arm had lower odds of antibiotic continuation when compared with the control arm. So 79% in the intervention arm discontinued the antibiotics, continued the antibiotics, while 84% in the control arm continued the antibiotics. So significantly less, odds ratio of 0.68, confidence interval from 0.47 to 0.98. The 30-day safety events, which included mortality, adverse events, etc., C. difficile infection, etc., were similar between the arms. So you can safely discontinue antibiotics if they are have negative cultures and go through this extensive safety checklist. Simplified trial was one step ahead. These were patients whose blood cultures grew Enterobacteriaceae, E. coli or Klebsiella or other Enterobacteriaceae, were empirically started on an anti-pseudomonal beta-lactam like meropenem, imipenem, piperacillin tazobactam, ceftazidime or cefepime. And the culture came back as it was susceptible to antibiotics like cotrimoxazole, amoxicillin clavulanate, ciprofloxacin, cefuroxime, etc. And they were randomized either to continue discontinuation of the de-escalation to one of these antibiotics, so continuation of the broad-spectrum antibiotics. The de-escalation antibiotics were amoxicillin, ampicillin, cotrimoxazole, amoxicillin clavulanate, ciprofloxacin, ertapenem, etc. And they found that cure rates were non-inferior to continuing empiric anti-pseudomonal drugs. So there was no difference in the cure rate, clinical cure rate. Adverse drug reactions, including C. difficile and mortality rates, mortality was extremely low, were similar among both the groups. So these two trials, randomized controlled trials, very high level of evidence, show that de-escalation is a safe strategy and you can substantially reduce the usage of antibiotics. It does not adversely impact mortality, relapse, reinfections, etc. So our patient S, the urine and blood cultures grew E. coli. It was resistant to cotrimoxazole, ciprofloxacin, third generation cephalosporins, piperacillin tazobactam. It was susceptible to ertapenem, imipenem, and meropenem. So meropenem was de-escalated to ertapenem. So this patient is doing well. We were able to taper off the inotropes. The kidney injury improved. Patient became afebrile. At that time, this was the culture report, and the meropenem was de-escalated to ertapenem. So anti-pseudomonal drug, a drug with an Pseudomonas aeruginosa spectrum, anti-pseudomonal spectrum, was de-escalated to a narrower spectrum, carbapenem, ertapenem. The third is stopping antibiotics. So when you give antibiotic to any patient with infection, you're worried about the length of the course of antibiotics. So how long is long enough? First and foremost, you want a relapse-free cure. So these patients, pyelonephritis should be cured and pyelonephritis should not relapse, although there are other reasons for relapse. Also, that also should be tackled. Second thing is that you want minimal or no damage to the commensal flora, which are the good bacteria, and your usage should not promote emergence of resistance or do it to the minimum extent possible. We will look at published studies, meta-analysis, and randomized controlled trials, which have compared shorter courses of antibiotics with longer courses. This is a fairly old paper, 2013 from CID. This is looking at antibiotic therapy of acute pyelonephritis. They compared patients who got shorter course. This is less than equal to 7 days with longer courses. And you found that clinical failure at the end of therapy of the longer course, that was the primary outcome, did not significantly differ between the two treatment arms. They were similar. Treatment outcomes were similar. And this is the relative risk and the confidence interval. So it crosses the null value of 1. So it's not a significant result, but it's similar. It's neither inferior nor superior. This is community-acquired pneumonia in adults. There are 5 RCTs recruiting almost 1,600 patients. Short course therapy was from 3 to 5 days. Longer course was from 7 to 14 days. And you can see that all these trials consistently showed that there is no difference. So wide variety of patients, wide spectrum, severe pneumonia, hospitalized pneumonia, antibiotics like quinolones, beta-lactams, combination. Whatever way you look at it, there is no difference when shorter courses are compared with longer courses. This is 7 versus 14 days antibiotics for bloodstream infections. And this is a meta-analysis published very recently. And the primary outcome was a 90-day all-cause mortality. And they looked at both the intention to treat and the protocol analysis, showed that it was non-inferior. Whether you look at it, the intention to treat or the per protocol analysis, whether you look at it in the Bayesian analysis or frequentist analysis, the 7-day course was non-inferior to the 14-day course. This is the REGARD VAP trial published in a recent issue of Lancet Respiratory Medicine. About 460 patients with ventilator-associated pneumonia in 3 Asian countries, Singapore, Nepal, and Thailand. Once the patient became afebrile for 48 hours and hemodynamically stable, they were randomized to antibiotic course less than or equal to 7 days versus the usual care. And the intervention arm, the median duration of antibiotic therapy was 6 days, while in the control arm, the antibiotic duration was 14 days. They looked at 60-day all-cause mortality. The red line is the usual care, and the green line is the short course strategy. You can see that there is absolutely no difference in the 60-day mortality. So whether you use the intention to treat or the per protocol analysis again, it did not cause a non-inferiority margin. So pyelonephritis, community-acquired pneumonia, ventilator-associated pneumonia, bloodstream infections. We know that short course therapy is at least non-inferior to the longer courses of therapy. VAP, it's only a single randomized control trial. All the others are multiple RCTs. There are other potential advantages for short course therapy: less adverse drug reactions, lower length of hospital stay, and of course, lower costs. But there are some caveats you should be aware of. You always should use adequate dose and frequency, what is called dose optimization of the antimicrobials. Remember Alexander Fleming's famous statement, if you use penicillin, use enough. Adequate source control. In the bloodstream infection trial, all the patients who got short course therapy had adequate source control. Remove the line, drain the abscess, do debridement, extremely important. Short course therapy is only if you can ensure adequate source control. You should make sure that you are using antibiotic which penetrates well into the site of infections, and patient has normal host defenses. May not be appropriate for patients with who are neutropenic or who are heavily immunosuppressed. What are the situations you may need longer courses? I mentioned about inadequate source control. Infections involving some sanctuary sites like biofilms. Remember biofilms. Number one, inadequate penetration of antibiotics into the biofilm. Second is that bacteria go into a state of reduced metabolism. So with biofilm-associated infections, infective endocarditis, foreign bodies, notoriously difficult to treat. Osteomyelitis is another sanctuary site because of the microenvironment inside the bone. Severely immunosuppressed host, and specific pathogens like brucellosis and melioidosis, you need longer course of antibiotics to prevent relapse. So to conclude, I will sum up my 3S approach. Number one is a plea to all of you and everybody whom we are going to interact with. So be skilled diagnosticians and parsimonious prescribers. So make a diagnosis. Does this patient have a bacterial infection? And how important is it to start immediate antibiotic therapy before we have reports of culture and susceptibility back? So prescribe only antibiotic only when antibiotics are likely to make a difference. Most importantly, seriously ill patients like septic shock, bacterial meningitis, pyelonephritis, necrotizing fasciitis, febrile neutropenia, etc. And when you use antibiotics, use enough. Dose optimization. Remember Alexander Fleming's statement. And antibiotic orders are never static. Review the orders daily. The aim is to de-escalate and maybe even stop antibiotics. And whenever you are treating antibiotics, now we have ample evidence. best quality evidence, evidence from well-designed randomized controlled trials and meta-analysis. Most infections can be treated with short courses, and they are as good as longer courses with less cost, less side effects, less resistance. So I'll end my presentation here. Thank you once again for patient listening. Thank you once again for the opportunity. I end my presentation with the invitation to all of you to attend our National Society meeting, SITSCon 2025, 15th Annual Conference in Mumbai. You can go online and register. Thank you very much.
Thank you very much, Dr. Abraham. In the interest of time, we can take only one question. Dr. Abraham, you said something about the prolonged infusion of beta-lactam antibiotics for sepsis in the ICU. What do you mean by prolonged infusion of antibiotic? Is it a 24-hour infusion, or as usual we give about 1 to 2 hour infusions of each dose? What do you mean by that?
Can you hear me?
Now we can hear you, yes.
Yeah. So thank you for asking this question. Prolonged infusion, if you take the example of meropenem, you give somebody with normal renal function, patient is in the ICU, the diagnosis of sepsis or septic shock. You give a 1 gram dose over 30 minutes or a bolus, followed by 3 gram infused over 24 hours through a dedicated line using an infusion pump. That is continuous infusion. The two antibiotics for which we have evidence for this is piperacillin tazobactam and meropenem. They have been studied most extensively. That meta-analysis I quoted, and the largest of all the trials, the BLINK-3 trial, used this protocol.
Right, thank you. Right, so we'll move on to the next speaker. Next speaker is Dr. Afrinesh Amir, currently designated as Project Director AMR at the National Institute of Health, Pakistan. And Dr. Amir holds several qualifications, including MPhil, PhD in microbiology, MPH, and PhD in public health. And she is going to talk to us on novel antibiotic delivery methods. Over to you.
Hello and a very good morning to all of you. Thank you for the kind introduction, and I thanks the organizing committee for inviting me over here, the Infectious Diseases Forum and the conference committee organizers. I am Afrinesh and I'm working in National Institute of Health in Pakistan for the last many years. And today I'm going to talk about the novel antibiotic delivery methods. So to begin with, the slides are not moving, I guess. It is. So my talk is going to cover some of the aspects that I presented over here. I'm going to talk about why there's a need for an effective delivery method, and I'm going to talk about the delivery challenges that we see. And then the discussion will be towards the antibiotic delivery methods. Particularly, we talk about the OPAT in detail, and then some of the novel technologies and methodologies that can help us in reaching our goal in effective delivery methods for the antibiotics. And finally, I conclude towards the principles to consider for the antibiotic delivery. Okay, so to begin with, why there is a high need for the effective delivery methods. We keep on listening from our previous speakers as well. So there is a clear consensus from everybody, from all of us, that the delivery methods are required to ensure the therapeutic levels of the antibiotics, they reach the infection site, and we reach a successful treatment outcome for the patient. The other concern is that when we have this effective treatment, it reduces the severity of the disease and it reduces the complications. And there's an overall impact on the healthcare economy, healthcare system, and there is a lesser hospital stay within the hospitals, and the patient outcome improves. There is lesser morbidity and mortality that is associated with it. And then we have seen that when we have a targeted drug delivery, we can see that there is decreased side effect or the toxic effects for the drugs. And eventually, there is one side that we are keep on looking, it's the clinicians, but the patient side is also need a concern for the effective delivery. Patient education in terms of the compliance, and patient education to patient support in terms of the simplified dosing regimes and the reduced side effect, it is more important. It's not moving actually. Thank you. Okay, so the delivery challenges that we can see with the antibiotics. The biggest challenge is that for the antibiotics, we want a targeted specific site delivery, and we need to ensure that the antibiotics, they reach the infection site very effectively. The other biggest challenge that we have seen over the years, it's the development of the antimicrobial resistance, and now this has become a serious concern. Keeping this in mind with all the clinicians sitting in this forum, that they should consider that antibiotics, they should be used very preciously, and they should be considered a precious thing because of the number of the reasons discussed by my previous speakers as well. The poor penetration, some antibiotics they fail, they struggle to penetrate to the tissues and the cell, and accordingly to the patient condition, the requirement, the need, that antibiotics should be prescribed. The toxicity and the side effects is another big challenge with all the antibiotics. Short half-life with the antibiotics, and Dr. Ibrahim also discussed about the biofilm production by the antibiotics, and again, it is further adding to the challenge towards the effective antibiotic delivery. So what are the different antibiotic delivery methods? I'm going to describe over here about the parenteral routes. The most common, the IV antibiotics, they are mostly used for the severe or the life-threatening infections. There are intramuscular routes which are used for the mild to moderate infections, and then we have the subcutaneous routes for the antibiotics. For the vascular access devices, we have different methodologies available. The most common, they are the peripherally inserted central catheters, which are mainly used for long-term infections, and then for the long-term duration as well. And then they have a central access, and they can be used for weeks to months. When we talk about the central venous catheters, they are again used for the prolonged therapy, and they are mainly used in the ICUs and the critical care. For the midline catheters, they are now preferred approach. There are a number of studies being conducted that have tried to compare the midline catheters with the PICC, and they have identified that midline catheters, they are again for the peripheral veins, and they have shown a better result as compared to the PICC. And they are mainly used for the moderate term therapies for a period of 1 to 4 weeks. And then we have the very commonly used peripheral IV cannulas, which are used for the short-term use for 3 to 5 days and can be applied on hand or forearm. The oral and the topical routes, we are all well aware of oral antibiotics, and the topical used for some of the infections related to skin and soft tissues, particularly for eye and ear infections. Other delivery methods include inhalational antibiotics, and the point of discussion for today is the OPAT, that is the outpatient, for the outpatient parenteral antimicrobial therapy. So OPAT is a consideration that has gained serious significance over the years. That as a clinician, we should know that how much this is important, and how much this can be a lifesaver or a cost-effective methodology for the number of the patients that we are dealing with. So this is actually the administration of the IV antibiotics outside the hospital settings. And this is ideal for the patients who are stable enough that they can get the antibiotics outside the hospital setting. And this has a number of the beneficial effects that we are going to discuss in the next slides. Whenever the patient is not in the hospital setting, he is being saved from the number of the things that we can see in the hospital. It can be either hospital-acquired infections, poor hygiene, or IPC practices that can further lead him to other infections. So OPAT is one of the methodologies that is suggested, particularly for the stable patients. IDSA has defined the OPAT as the administration of the parenteral antimicrobial therapy in at least 2 doses on different days without intervening the hospitalization. So what are the different indications? So commonly used OPAT is being prescribed for the bacteremia, for the cellulitis or the surgical site tissue infections, bone and joint infections, endocarditis for particular selected cases, and post-surgical infections. Patient selection is the biggest criteria for the OPAT. You have to be very much careful looking at the patient clinical status, if he is stable enough, if he is safe enough to that he can be treated well in the home, in the house environment, in the home. And then the major factor is if the patient has the access to the trained staff or the caregivers, reliable venous access that needs to be considered. And then very important is that for certain drugs, there is a therapeutic drug monitoring which is required. So if you are prescribing something for the IV for the patient, then this needs to be considered that there's drug monitoring, and also there is no ICU level monitoring is required for that particular patient. So these are some of the commonly used antibiotics which are being prescribed in the OPAT, in the outpatient therapy centers. Teicoplanin is one of the commonest, and for the teicoplanin, the frequency is usually once daily, and it is used for the MRSA and the gram-positive infections. Its monitoring, it leads to minimal toxicity, so you may not need to be worried a lot for its daily monitoring or the weekly monitoring. Vancomycin is a drug that has been frequently prescribed for the OPAT. It is prescribed in 2 times in a day, particularly advised for MRSA and bacteremia. Vancomycin requires a particular renal monitoring. You need to be very much careful about the renal function test whenever the patient is advised for the vancomycin. Similarly, for the ertapenem, it's advised once daily, and it is mainly prescribed for the ESBL producing organisms. And monitoring is again the renal function test needs to be monitored. Colistin, as mentioned by Dr. Abraham as well, that has been advised either BID or TID, and mainly required for the gram-negative infections. Renal electrolyte monitoring is required for whenever the colistin is prescribed for the IV OPAT. For amikacin, it's again once daily. Gram-negative bacteremia is the use area where we use this amikacin, and it leads to disturbance of the renal function test and the autotoxicity that needs to be monitored. Gentamicin, again prescribed once daily, prescribed for the endocarditis and urinary tract infections. Again, autotoxicity and RFT is a concern. Amphotericin B, electrolytes, and the renal function test, they are of concern. So for the OPAT, for the outpatient therapy, the administration rate is a safety priority. For the amphotericin B, it is always prescribed to go for a slow infusion over a period of 2 to 6 hours. For the vancomycin, it is more than 1 hour. Otherwise, it can lead to the Redmond syndrome, but if it's given appropriately, can prevent the Redmond syndrome. Acyclovir is again prescribed. It will be given over a period of 1 hour, and it can prevent the nephrotoxicity. And so operational requirements, they are very important. Whenever you are thinking a patient to go for the IV antibiotics at home, please consider these points. There should be a trained healthcare staff looking at the patient. There should be a proper medication administration protocols shared with the patient and also with the nursing staff or the healthcare provider. The line care the protocols that should be very much followed, that we commonly see in the sepsis that affects with the catheter-associated infections. Cold chain maintenance for the antibiotics, and schedule the antibiotics according to the patient compliance, so that to have the maximum benefit from the patient. For the peripheral catheter lines and for the midline catheter lines, it is suggested to go for the weekly dressings. Weekly dressings are required. Daily inspection for any signs of infection. The flushing protocol should be followed, and avoid any moisture and contamination to the site of the catheter. Some of the safety protocols in the OPAT, standard protocols for infusion and monitoring should be shared with the clinician, with the nursing staff, with the patient as well. Communicate with the physician on the routine basis. There should be a good channel between the patient and the physician. Again, the patient should be, then education for the patient as well about this type of the treatment that you are giving to him. It's just not, he should be very much carefree towards his approach. He should be careful with the number of the steps that are associated with them, with the cold chain maintenance, with the care of the catheter, with the timing of the infusion required. And OPAT is very safe and effective methodology, and it is very cost saving if it is done in the right way. Now, talking little about the drug delivery systems. So over the time, what we have seen, the challenge with the antibiotics, and it is going worse with the emerging antimicrobial resistance and the number of the patient conditions and the clinical conditions that we see. So there are a number of the things that are considered while developing these novel methods. The consideration is that we have to enhance the pharmacokinetic properties of the antimicrobial agents. We have to improve their effectiveness, and the best thing is that we have to reduce the toxicities that are associated with these drugs. So some of the models that are being tested, and there are a number of the clinical trials that are being done. One of this is the targeted antibiotic release. So there are a number of the new novel technologies, including the nanoparticles, that are being used by different researchers across the globe. And they have seen that when using this targeted drug delivery system, we would be able to achieve a higher concentration of the antibiotics at the site of infection. We see increasing local efficacy for the antibiotics, and the best thing is that we reduce the toxicity associated with those drugs. Very recently, a study has been published that was using the vancomycin along with the nanoparticles, and they have seen that the targeted drug delivery that has led to decrease in the toxicity associated with the vancomycin. Similarly, when we talk about another method, that is a sustained local release, that is doing a wonder in the field of the research right now. What we have seen that the drugs, they are associated with some kind of nanoparticles or microspheres, and then this leads to a sustained release of the antibiotics at the site of the infections. For a period of over 4 weeks or 6 weeks. And that slow release, that is helping in a lot of infections, and for example, in the bone applications, and they're reducing the toxicities, and they're promoting the treatments. Another approach that is being tested by the researchers, that is the stimulus responsive drug delivery systems. And again, in these methods, these are the materials which can release the antibiotics in response to specific conditions, like there's a stimulus like a pH change, or the microbial recognition patterns, or the external stimulus like light or ultrasound. And particularly for the cancer therapies, these ultrasound-based drug delivery systems, they are localized for the localized cancer therapies. This is doing a lot of good things. Enhanced antimicrobial activity, what we have seen that the drug delivery systems, if they are joined with the other antimicrobial peptides or the gold nanoparticles that have innate activity against the microbes, so that gives a synergistic effect, and we reach our target outcome. And very recently, this Trojan horse strategies that are being suggested and that are being practiced, natural pathways like the CYDRO4 dependent iron uptake mechanisms, they are being utilized to transport the antibiotics into the bacterial cells, and this is helping to overcome the resistance as well. Some of the examples of the drug delivery systems that I have just discussed: liposomal amphotericin B for fungal infections, that is being utilized. Then we have seen the antibiotic-loaded bone cement for preventing the post-op infections. Wound dressings with the metal or the polymer-based agents like nanoparticles that are being used. And yes, just coming towards some of the other approaches, the nanoparticles that I have already discussed. One of the novel technologies doing a wonder in the field of the research. They have nanoparticles, they have a high surface to volume ratio, and this give them the edge that you can add a large amount of the antimicrobial or any required material to them, and this can give a good impact towards your, in a smaller volume, you can achieve a larger impact. Similarly, photodynamic therapy, the light, using the light or the ultrasound, there are different mechanisms that are being used, which are used to produce the reactive species that can kill the bacteria. And this is effective against many MDR and XDR species that we're seeing these days with the pathogens. Hybrid models, I have briefly discussed with you earlier as well. The hybrid models includes the nanoparticles engaging with the antimicrobial peptides, or we can add the nanoparticle with the different antibiotics, so that gives them an added advantage. Phage therapy, again the bacteriophages, they are being utilized for the number of the infections, and they are giving a promising treatment options against the drug-resistant bacteria and the pathogens. So I guess this is the last slide, the principles to consider. Thanks to Dr. Ibrahim for covering majority of the points that I'm presenting over here. So whenever you are going towards effective delivery, antibiotic delivery, you have to consider these three things in mainly. That can be the pharmacodynamics and the pharmacokinetics. What is the dose of the antibiotics required? What is the concentration of antibiotic that is required? Is the antibiotic has a good tissue penetration? Is the bioavailability is good? These points needs to be considered. Again, stewardship. And stewardship is the much needed approach these days. And it's a rational use of the antimicrobial. It does not always means to stop the antimicrobial. Stewardship means that you have to be very much rational towards your antibiotic prescription. You have to be careful. Either you can escalate the antibiotics or you can de-escalate the antibiotic, and that needs to be considered with the patient ongoing clinical conditions and ongoing laboratory test, and accordingly you can treat the patient. And finally, the patient safety is a concern for all of us. And you keep an eye towards adverse effects, any allergic reaction, nephrotoxicity, and again, you have to develop some strategies to control these adverse effects according to your monitoring and treatment options. And with this, I come to the end. Thank you so much. If you have any questions.
Thank you very much, Dr. Amir. So we can entertain one question because of the time constraints.
Sure.
If you have any burning questions, we can ask. There are microphones over here.
Thank you for that excellent talk. Can I ask, when you're implementing OPAT, how did you convince the authorities to fund to this kind of out-of-hospital experience? Sometimes because we are overburdened while we are inside the hospital, sometimes the administrators are not keen to look out for such a strategy. How did you start this going?
How to start with the stewardship or your best practices? I didn't get it, sorry.
The OPAT.
OPAT, okay.
Yeah.
No, exactly. That needs to be considered very seriously. The OPAT, whenever you are starting the OPAT mechanism, that needs to be discussed at all the levels. It's not a one person's job. You have to be talk to the administration, with the antibiotic committee, with the IPC control committee. They all need to sit together, even with the IPC committee, and there needs to be done a consensus. Now the hospital is ready for this thing. And you are right, at times the higher hierarchy and the clinicians and the administration, they are busy in the other things and you don't get the opportunity to talk to them and start this initiative. But I think it's an institutional policy. It should be an institutional policy. I have seen a number of the hospitals in Pakistan who are practicing this OPAT, and they are seeing wonder results, like the healthcare cost is improved, and then you have seen a less burden on the patient. But again, that has been done at the institutional level, that there's a consensus that this needs to be done. If the clinician is starting with an OPAT therapy, they are in contact with the hospital administration, they are contacting with the patient. But at the individual level, I must suggest that OPAT can be started, but again, you have there's a number of the guidelines available. I have presented a link in my presentation. That is the IDSA guidelines. And they keep on telling you that how can you start, and many of the materials that I have taken is again from the IDSA and the ECMID and the other guidelines. So that can help you to identify at the individual level, but preferable is that it should be the institutional level, and the institution should take an activity, and it will definitely cut down the cost on the hospital as well. And for the patient safety, this is the best approach.
Right. Thank you, Dr. Amir, for that informative lecture. And next, we'll move on to the case-based discussion, which is scheduled. And I would like to invite Dr. Dumita Govindapala, who is a senior lecturer at the Faculty of Medical Sciences, University of Sri Jayawardenepura, and an honorary consultant physician at Colombo South Teaching Hospital, to conduct the case-based discussion. Thank you.
Thank you, Dirshan, for those kind words of introduction. May I first introduce the panelists for this case-based discussion. Our first panelist is Professor Ozzy Abraham. Professor Ozzy Abraham is the head of the Christian Medical School, Velo, India. He will be joining us virtually. The second panelist is Dr. Afrinish Amir. Dr. Amir is an AMR consultant, and currently she is serving as the AMR project director at the National Institute of Health, Pakistan. And the third panelist, for this expert panel discussion is Dr. Madhumani Abeywadana. Dr. Abeywadana is a consultant microbiologist serving at the National Hospital, Kandy. She is an active member of the AMR core group in Sri Lanka. May I now cordially invite Dr. Amir and Dr. Abeywadana to the stage to join me to conduct this panel discussion. And the case for this panel discussion will be presented by Dr. Ravindu Kodithuakku. Ravindu is an enthusiastic young physician who is serving at National Hospital, Galle. Ravindu, would you join us? Yes. Over to you, Ravindu.
Good morning, everyone. Thank you, Madam, for the kind introduction, and I must thank the college for this opportunity. So today I will be presenting to you all a case that is all too familiar for all of us, which is a case of a complicated infection with several it's sort of a roller coaster ride. So, and it will highlight the key points that were made in the previous two speeches, as well as our topic, right drug, right way. And the outline for today's talk will be, I will introduce to you our patient with a clinical vignette, which includes his initial assessment, the management, the complications that we had, and the ending. Spoilers, he made a good recovery. And we'll see what were the challenges we faced. We get the opinion from our experts during the course of this presentation, and a few take-home messages that we can learn from this case. So let me introduce to you our patient, Mr. S, a 70-year-old gentleman from southern Sri Lanka, coming to the ET of the National Hospital of Galle with fever and dysuria for 1 day. So the important thing is patient is coming with just 1 day of history of fever and dysuria, as well as he had back pain or loin pain as well. In the background, patient has had type 2 diabetes with sort of a poor control for 10 years, last 10 years duration, and also he's having chronic kidney disease stage 3B with a EGFR of 32. I'm mentioning this because it's important for us for our management. And another important history is that he has had recent left-sided pyelonephritis, which I will explain to you in another slide, and that has happened over 3 months back. So on admission to the ETU, he was tachycardic. He was triaged as a category 3 patient based on the pulse rate of 110 when he was afebrile, and blood pressure also on the lower side, so with 100/70. And on examination, it was noted that he was having left-sided loin tenderness or renal angle tenderness. Other system examination did not reveal much of anything. And coming to now at the ETU, initially blood was drawn and the urine was collected for investigations. And fluid resuscitation was started because the blood pressure was on the lower side. And a clinical diagnosis of possibility of urosepsis was considered and seen by the physician at the ETU, and he was started with the first dose of IV antibiotics, considering that he is possibly having sepsis. And then he was transferred to the ward for further care. So just to highlight you the previous presentation, he was treated for a left-sided pyelonephritis in January 2025, where he presented with similar symptoms of fever, dysuria, and dark-colored urine, and the renal angle tenderness. And this time, this urine culture was positive for Klebsiella species, and but however, his blood culture was negative. And this pyelonephritis was confirmed with ultrasound scan, but there was no abscesses or perinephric collections. And then he was treated with IV meropenem according to the ABST that was derived from the urine culture, meropenem for 2 weeks with renal adjusted doses. And the repeat urine culture after he was discharged from the hospital was negative after the completion of antibiotics. So now coming back to our current presentation, he was given IV meropenem 500 milligram empirically considering the patient's clinical condition at the ETU. And this was, but prior to that, cultures for urine and blood both were obtained. So now we move on to the first set of questions to our panel of experts.
So our patient is a 70-year-old man with a history of diabetes and CKD stage 3, presenting with urosepsis. This was the second presentation of left-sided pyelonephritis within a period of 3 months. He was empirically started on IV meropenem after obtaining cultures in the ETU. So my first question is to Professor Ibrahim. In an era of multi-drug resistant gram-negative bacilli causing urinary tract infections, how should we tailor our empiric antibiotic therapy for patients presenting with complicated urinary tract infections?
Good morning, everybody, once again. Thank you for the case presentation and the question. Can you all hear me?
Yes.
Okay. So, initial empiric therapy depends on your clinical diagnosis, depends on how sick the patient is, depends on the anticipated microbial etiology and antimicrobial susceptibility report. So if you are in India, somebody with acute pyelonephritis, E. coli being the most common causal etiology, and very high rates of ESBL producers, third generation cephalosporin resistance. My initial empiric choice, especially in a sick patient, will be meropenem. And I will use the full dose of meropenem, 1 gram Q8 hourly, for at least the first 24 to 48 hours for all the reasons I mentioned in my presentation, what Dr. Afrinish made in her presentations.
Okay, I think you have answered my second question also about the initial dosing of empiric antibiotic therapy. So I think, Ravidu, we can move forward.
Yes. So now the patient is in the ward. So there we obtained a more detailed history. Thorough examination was performed. And considering that he's a diabetic, 1 or 3 oral hypoglycemics, namely metformin, glycoside, and sitagliptin, we changed him to soluble insulin for a tighter blood glucose control in this period of infection. And again, as highlighted, meropenem was given for 48 hours of 1 gram, although the initial dose was given at the E2 as 500 milligram, we have continued 1 gram for 48 hours. And other specific investigations and imaging was arranged. And by the day 3 of admissions, we get the ultrasound scan abdomen was done. And I must highlight you the size of the abscess. The abscess perinephric collection was noted of 19 into 10 into 10 centimeters. This is not a mistake, it's centimeters. So it's a very huge abscess and pretty much suggestive of a perinephric abscess. So these were the summary of the initial investigations at the ETU. So there is mild leukocytosis, but this has changed after the admission because he came in the just following 1 day of symptoms. And initial CRP is 102, but I want to highlight the serum creatinine is already 271, which is his baseline is around 200, so it has gone up. And as you can see, potassium is also a little bit on the high side, so he is possibly having a acute kidney injury as well. And the UFR is showing pus cells of 35 to 40. So as discussed in the previous presentation, he is having pyuria, with the history with the clinical symptoms. So this we are confirming the clinical diagnosis of left-sided pyelonephritis. And initial urine culture sample was negative. However, the blood culture that was obtained prior to antibiotics, preliminary report was informed to us from the lab that it is growing some kind of a gram-negative bacilli. However, the final report did not show any growth. So now we come to the next set of questions.
So this patient, although the urine and blood samples were obtained prior to the antibiotic therapy, initial antibiotics, both the blood culture and the urine culture were negative in this patient. However, the preliminary assay of blood culture had shown some gram-negative bacilli. So my question is to you, Dr. Abeyvardhana, what are the possible explanations for those negative cultures and the presence of gram-negative bacilli in the preliminary report?
I think the urine culture has become negative. It could be because now it seems like because we have already got the diagnosis of abscess, so probably the patient was having the abscess rather than the at this moment pyelonephritis. That could be one of the reasons. And we have seen gram-negative bacilli in the gram smear on the blood culture bottle when it became positive. I mean, when it must have alarmed. So usually we see gram-negative bacilli when the patient is, see and don't grow when the patient is on antibiotics. The other reason is anaerobic organisms. But in UTI, we hardly get anaerobes. And so according to the history, the patient has not been on antibiotics. But if we know our patients, and probably must have taken antibiotics before he came to the hospital. That is one of the reasons. But still, I think, this is the reason for seeing and not growing. But even in pyelonephritis, we won't get 100% culture positivity. It's likely somewhere like 50% or so. So even blood culture, we don't get 100% positive in abscesses especially, because it is a localized thing rather than systemic at this moment, because CRP is also not very high. These could be the possible reasons, in my opinion.
I think the patient was not on any prior antibiotics. Any other inputs from the other experts?
I agree with Dr. my fellow colleague on this thing. Yeah, exactly the same thing. The patient must have taken some antibiotic previously that has obscured the result findings that we are seeing with the culture. And that could be the only reason, because the infection is quite high. We have seen high pus samples within the urine, and it is a patient is symptomatic. The clinical conditions are there. The only reason can be that he has taken some antibiotics previously that has limited the appearance of the pathogen within the cultures.
Molecular diagnostic tools are widely used in the field of infectious diseases nowadays, mainly for diagnostic purposes and also for certain management aspects. My next question is to you, Dr. Amir. How can emerging molecular diagnostic tools improve pathogen identification when the conventional cultures are negative or inconclusive, like in this case?
Yeah, I totally agree. With the emerging technologies, we see a number of good findings. They are like molecular technique. They are based on the PCR. Even with the smaller amount of the pathogen within the sample, they are able to replicate it in a number of huge quantities so that you are able to pick it up. And besides, this is the PCRs, the sequencing is another approach. But with the emergence of the methodologies like BioFire, we have seen that within 4 to 6 hours, you are able to identify the pathogen within the samples. It is again a direct method. You don't need to do the cultures and then go towards a PCR. So with the BioFire kind of technologies, I think we are going ahead and we are moving towards from the direct sample. We take the sample, we put it in the machine, it replicates the pathogen if it is present in the sample. And this is a rapid PCR, and we see the results within 4 to 6 hours. And this is kind of a lifesaver for many of the infections, though it's a very costly approach, but again, it's a very effective approach in diagnosis. And in cases like these this can be really helpful.
Yes, I agree with you. Moving on to the next question. In evaluation of complicated urinary tract infections, imaging is a must. So in this patient, also the ultrasound scan which was performed on the day 2 has revealed a large perinephric collection. However, the conventional ultrasound assessments can be not sensitive enough to detect early perinephric collections. So my question is to Professor Ibrahim again. How can, in the context of recurrent urosepsis, what are the most sensitive and specific imaging modalities for early detection of perinephric abscesses, especially in patients with diabetes where this is a possibility?
Okay. Ultrasound examination of the KUB region is less expensive, widely available, and does not expose the patient to radiation. However, as you pointed out, it is highly observer dependent. So if you have facilities, CT scan of the KUB region will be the best. But then having said that, availability, cost, and radiation are issues with the CT KUB.
We'll proceed with the presentation.
So we come to the next junction. So we have discovered a huge ball of pus. So now we go for the multidisciplinary team input. So there is further specialist input from the genitourinary team. We have referred to them, and they have identified it as a grave problem, and they actually needed contrast enhanced CTKUB for a better assessment. And they also wanted us to discuss with the patient the possibility of a nephrectomy if this infection does not settle with the treatment, antibiotics, and possible drainage. And however, because of this patient's condition of the chronic kidney disease, we discussed with the nephrology team as well, and they were not happy to expose this patient to contrast material as the patient was already in an acute kidney injury state. So with the help of the interventional radiology team, we inserted a pigtail catheter into the perinephric collection and obtained samples for the culture and the ABST. However, unfortunately, it was not draining completely well, and patient got the pigtail dislodged about after 2 days of the insertion. And continuing on that, we'll just add some few more questions as well.
So this is a constant problem that we encounter in day-to-day practice, the GU team requesting contrast imaging for better visualization of kidneys and the nephrology team declining it considering the renal functions. So my question is again to Professor Ibrahim, what are the latest advances in imaging protocols that optimize diagnostic yield while causing minimum nephrotoxicity in patients with AKI, especially when they are needed detailed evaluation of complicated renal infections?
Am I audible?
Yes, we can hear you.
Okay. The short and simple answer, if the treating team feels that the patient with kidney injury needs a contrast-enhanced CT scan, please go ahead. The issue of contrast-induced nephropathy has been overemphasized. That is my understanding, and that is the current literature also. So if the treating team needs that, this is required before planning a definite surgical procedure. In this patient, source control is life-saving. He needs drainage of the perinephric abscess. So if the treating team feels that there is a need for contrast-enhanced CT scan, please go ahead. The issue of contrast-induced nephropathy has been overemphasized.
Do you recommend any special preparations like IV hydration, sodium bicarbonate, or NAC?
Yeah. Things as simple as ensuring that patient is adequately hydrated. I'm not very sure about the additional advantage of bicarbonate and NAC, maybe consult your nephrology colleagues, but certainly well hydrated. Thank you very much for pointing that out.
Thank you. So, according to the MDT decision, pigtail catheter was inserted and the abscess was drained. So my question is to you, Dr. Abhivardhana, is drainage required for all perinephric collections? And when indicated, how should the timing and appropriate modality of drainage be determined?
No, all abscesses need drainage because if it is small and treatable, you can still carry on with antimicrobials. But if the patient, the abscess does not respond within a few days to the given antibiotics and the patient is deteriorating, especially if the abscess is more than 3 centimeter, the drainage is required. Not response, as well as the little larger abscesses about 3 centimeters, and where you can still drain with percutaneous drainage you can do. But with that also, if the patient, if it is a very large abscess which cannot be drained properly with percutaneous drainage, and then of course we may have to go for open surgeries, even as they have suspected nephrectomy depending on the condition.
Else to add, Dr. Amir?
Same thing. The source control is a must depending on the patient clinical condition. If the patient is responding to the antimicrobials, then you can go forward with the same methodology. But if the patient is not responding, the clinical condition is deteriorating, as we can see in this patient, in this particular patient, then it is suggested to go for the drainage. The source control is a must in any case, either through the antibiotics or through the operational procedures.
Thank you. Let's move on, Ravind.
So now we get the report that we all waiting for. In the 6th day of admission, we get the culture report from the abscess fluid that was drained, and it has shown heavy growth of Klebsiella, and it is sensitive to meropenem as well as piperacillin and tazobactam as well. And during this time, patient was catheterized, and we got a repeat urine culture. It was sent on the day 6th, and it has grown some Pseudomonas species, and it is resistant to meropenem but sensitive to piperacillin and tazobactam. So we move to the next.
Yes, although the initial urine culture was negative, the subsequent sample obtained during the ward stay has grown a Pseudomonas species in this patient. So how should the positive urine culture be interpreted in this clinical context? Should it be treated as a hospital-acquired urinary tract infection, or could it represent an asymptomatic colonization? The question is to Dr. Abhivardhana.
Can I know whether the patient was catheterized by that time?
Yes, madam.
Right, okay. In which case, in catheterized patient, most of the time we get colonization. So, and because it's very unlikely to have UTI with Pseudomonas and abscess with Klebsiella, which is not likely. I would have done I would have changed the catheter and repeat the urine culture if it was kind of like very suspicious. But I would have taken it as a colonizer than a real pathogen in a catheterized patient, especially we have some other pathogen sitting on.
Any different opinion of the other panelists?
Same thing. They repeat the culture, repeat the result for the urine culture because of the reasons that are mentioned just now.
Professor Ibrahim?
May I ask how the culture sample was collected?
From the catheter, so it was taken from a syringe from the catheter itself.
So I will, at the moment, I will not be considering this as septogen. I completely agree with Dr. Abhivardhana.
So then we come to the twist in our case. The patient during day 9 since admission, patient suddenly develops shortness of breath. And then blood pressure starts to drop when we need small dose of inotropic support, but patient is still in the ward. And there is a left-sided pleural effusion noted on examination. And we have performed a chest X-ray urgently. So this is the X-ray. Now, as you can see, the whole left side is white outed, and then this is the CRP trend towards this day 9. There is a sudden spike of the CRP going up to more than 200s, and with that, we have aspirated the pleural effusion. With the help of the cardiothoracic team, we have inserted IC tube for the drainage, and it drained over 1,400 milliliters of fluid. And this pleural fluid was also sent for microbiological and biochemical analysis. And considering this change in the clinical setting, it was decided and given the renal functions and the CRP trends, patient was switched to IV piperacillin tazobactam, 2.25 gram every 8 hourly. And this is the serum creatinine chart around that time. It has, again, it was spiking. And we have repeated the ultrasound scan as well, and it has shown the perinephric collection size has gone down 10 into 4 into 4 centimeters, but there is a large left-sided pleural effusion. And then, because at this time pigtail was dislodged, it was reinserted with the help of the interventional radiology team. And the pleural fluid analysis showed clear pyothorax with polymorphs of more than 200,000, LDH was 270, and the culture again grew Klebsiella. And we did additional investigations as well, considering the complicated nature of this patient's case. However, melioidosis antibodies were negative, and it was negative for tuberculosis screening as well. So now come to the next set of questions.
Most of the patients with complicated urinary tract infections will respond to initial drainage and appropriate antibiotic therapy, especially if it was started early. However, this patient, despite given antibiotics and the attempts to drain the abscess with a pigtail catheter, has deteriorated and he has developed a pyothorax over a few days. So my question is to Dr. Abe Vardana. What are the potential reasons for the clinical deterioration in this patient despite the initial therapy?
I think because it was said that catheter was removed, pigtail catheter was dislodged. Probably it was not drained enough during that time. And how the pyothorax became the possibility of pyothorax, whether it was leaking upwards or whether because it's the organism is Klebsiella, that again, it's not the most common pathogen which causes UTI. So he's a diabetic, so he has the reason to have Klebsiella, but Klebsiella can cause multiple abscesses also, like we know hypervirulent Klebsiella can cause abscesses, even multiple abscesses. So whether the patient has had two things at the same time, or whether the first one, which has been in the pelvis, has leaked to, I don't know anatomically whether it's possible. These are the two things. So obviously the drainage was not enough. That's what I think, because although we give antibiotics, because it is not getting drained properly, the source is still there. And that could have been the reason, because the organisms are trapped inside the body. And so the antibiotic cannot reach that into the abscesses properly. That it could have been the reason, in my opinion.
Okay.
The same, exactly. Initially, it was mentioned that it's a huge abscess. It may not be, the meropenem may not be responding. It has been started empirically. So that is the thing that needs to be considered. Culture at that time was negative. So it was again the treatment that was being continued without a good culture findings in front of you. So when the culture results, again, they show PIP test is sensitive and Miro was also sensitive, yeah?
Meropenem was.
Yes, exactly. It was also. But again, there could be any reasons to it. The large abscess or the site of the targeted, the reach of the antibiotic may be one of the reason. So I think at this scenario, when you have a number of options available from a list of the antimicrobial susceptibility pattern, the antibiotic should be changed because now the number of days have been passed, the abscess has been spread to the surrounding areas, and we have seen not a good response. There's a clinical deterioration.
If you have noted the ultrasound findings, the abscess size of the size of the perinephric collection has remarkably reduced over the time with meropenem. So, however, he has developed this pylothorax, which is actually very difficult to explain. Maybe it was another abscess because we don't have any imaging other than the ultrasound imaging which was done on the day 2 of admission. So I wonder whether we should have gone for a better imaging at the beginning. So my next question is also to you, Dr. Amir. Now, you agree with the switch of antibiotic therapy from meropenem to piperacillin tazobactam. What do you think about the dose? We have adjusted the dose according to the renal function. In a patient with severe complicated urosepsis with the pylothorax, whether you agree with this dose or whether we should have given a higher dose for this patient at this time.
Yeah, this is a concern that we talking about shifting of the antibiotics, the PIP test, and the patient, what we have seen with the CRP, creatinine levels, they are also of concern. But depending on the clinical condition, I think it can be shifted. I think my colleague can answer this thing.
Because if the source control was not properly attended, if it was a reason, I don't see any reason to kind of step down from meropenem to piperacillin tazobactam. It's kind of a stepping down, and it is an ESBL producer as well. Usually, we ESBL producers, unless it is urinary tract infection, we don't treat with piperacillin tazobactam most of the time. We go for meropenem. And probably this was misguided by the urine culture report, which came with Pseudomonas. And the other thing, if we go for piperacillin tazobactam, if the serum creatinine is higher than 20, I saw that creatinine level was very high. It is around 350, 400. I'm not quite sure whether it is, could be less than 20. In that case, of course, we may have to adjust the dose. But switching, I don't see much indication because the source is still there.
Professor Abraham, do you have any different?
Can I add one point? Being a microbiologist, what we have seen over the years is the carbapenemase production within the Klebsiella. AMC producing Klebsiella, they are there. And this carbapenemase production, it may not be picked very easily through the routine culture AST methods. So that can be the reason that we are not following the right culture techniques or the PCRs or the methods to pick up, and the pathogen has the carbapenemase gene within it, and it is showing somehow resistance to the meropenem, and that can be the one good approach. So looking at the bigger picture is always very helpful. Understanding the local antibiograms, the patterns, the trends within the society, the research studies, they always help to understand what is happening. At times we are all thinking on one line. We are thinking that the Klebsiella is always responding to meropenem. But with the emerging thing, what we have seen that it is AMC producing Klebsiella, they're very common. Carbapenemase production is very common. And it is not routinely picked up by the routine AST methods. So there are different other methods that needs to be done within on the bench that to identify that gene production. So that needs to be considered from the bigger perspective. Being a clinician, the AMR is the pathogen is the concern for all of us. So we should look from that angle as well.
Professor Abraham, do you have anything to add?
Yeah. Am I audible?
Yes.
Okay, two comments. Number one, unfortunately, the effort at source control was not optimal because the pigtail catheter got dislodged. Therefore, patient had hematogenous dissemination and formation of a pyothorax, empyema thoracis. Second question is about antibiotic. I will continue meropenem. If there is in vitro susceptibility to ertapenem, I will change meropenem to ertapenem. Why I will not start piperacillin tazobactam is the result of the Merino trial. It was patients recruited from our part of the world. Merino trial showed that for definitive therapy of Enterobacteriaceae bloodstream infection, meropenem was superior to piperacillin tazobactam. Originally about 8% difference in mortality. When they realized post-hoc analysis also 5% mortality difference. So meropenem is superior to piperacillin tazobactam for definitive therapy of bloodstream infections caused by Enterobacteriaceae.
Thank you. Ravindu will proceed with the presentation.
So we are coming to the end of the presentation. Now, actually, after the reinsertion of the pigtail, we managed to have a better source control. And with the IC tube and the pigtail, the patient made a gradual and complete recovery from the infection. So before this clinical deterioration, meropenem was continued for 10 days. And then it was changed for piperacillin tazobactam, and it was continued for 23 days. So in total, patient was having antibiotics for about 33 days, about a month. And there was improvement in radiological and biochemical, and as you can see, the chest X-ray has completely cleared, and the ultrasound also showed no perinephric collections, and there was only mild edema in the left-sided kidney, and there's no residual abscesses. And his renal function also returned to the baseline. And we did not go ahead with the CECT following the recovery. However, we did arrange a 2D echocardiogram just to screen for a possibility of infective endocarditis. His diabetes management was optimized, and he returned to the clinics with repeat cultures which were negative, and he's currently clinically stable and doing well. So we are at the end of the, I think, of the time with the
Yes, we'll try to ask few more questions from the experts. So this patient was given total of 33 days antibiotics, both meropenem and piperacillin tazobactam. Considering the large perinephric abscess in a patient with long-standing poor glycemic control and diabetes with poor glycemic control, and this is the second episode that he was second time he was presenting with left-sided pyelonephritis. So considering all these things, do you think the duration of antibiotic therapy is adequate, although the patient has recovered fully this time? The question is open to the panel. If any of you would like to answer the question.
It's given 33 days, it seems. So guideline says very a big, like 2 to 6 weeks, these are, I mean, when you evacuate the pus in, when you have controlled the source, I think 33 would have been enough in this case. I'm thinking about, because the respiratory physicians are very keen on keeping treatment for 6 weeks for pyothorax, but in this patient, I don't know whether, because we don't know the origin of the pyothorax as well, but since it was trained properly and obviously patient has responded, could have been, like, clinically, it seems patient has got better.
Thank you. So in the interest of time, I think we should conclude this session. But before concluding, I thought of asking this $1,000 question from Professor Abraham. So if this patient remains free of urinary tract infections for 1 year, would you consider starting SGLT2 inhibitors for his diabetes to achieve a good control?
Yes, absolutely yes.
Thank you. So I think we had a very fruitful discussion today about a patient presenting with recurrent pyelonephritis with background history of diabetes and CKD. So I would like to thank all three panelists on behalf of the Infectious Disease Forum of Sri Lanka. Thank you.